Maybe to just wrap up this conversation around kind of frontline IO-based treatments, is anybody have excitement about what they saw either at ASCO or things that they think are exciting going on over the last year, trying to either add, we've talked a little bit about Cosmic 313, and that was a challenge, triplet toxicity. But what do people think are going to be the most promising avenue of increasing cure, increasing deep responses, time off treatment, these things that we want for our patients? Anybody have any exciting insight? David, I'll start with you.
Well, I think the biggest thing that could impact cure is adjuvant PD-1, because there you're seeing improvements in disease-free and overall survival, and that could mean fewer people dying of kidney cancer. But and there's obviously a large group of patients that are going to be treated with PD-1, but we need to do a much better job at two things in that setting. One, trying to predict who's going to recur. Our current clinical tools are not great, and some of the exciting data coming out of this meeting, looking at blood biomarkers and things like that, which these guys can talk about more than I can, offers a future direction on that question of who might recur, but also who's going to benefit from treatment. Because we're clearly, if we're overtreating in some patients in the metastatic setting, we're certainly overtreating in the adjuvant setting, where 60-70% of our patients who are going to get the drug are already cured with surgery. So as a field, we need to agree that we're going to try to limit these drugs to the patients most likely to benefit. Otherwise we're going to be over-treating patients, which leads to cost, but also toxicity, which is real, with not just life-threatening toxicity, but life-altering toxicity for patients who would have been cured without treatment. So the risk, in my mind, the risk-benefit of IO is completely inverted in the adjuvant setting. I become much less optimistic about how we just can't blanket give patients these drugs in that situation, in my opinion.
So you're saying your understanding of this inversion is mostly, it sounds like from you, mostly because of our inability for patient selection?
I think it's both this lack of ability to predict who's going to recur, because I don't think the clinical criteria do a good enough job at predicting who's going to recur. So we need to improve on that. But it's also over-treatment leading to toxicity. I mean, when you add up the life-altering, life-threatening toxicity that happens in these trials, it's often in the small print of the trials. In at least my math, it's like 5 or 10% of patients will get some impact that's significant. That number is very close to the absolute benefit in overall survival that we see currently with these drugs, not just in kidney cancer, but in a variety of tumor types. So as long as that's the case, we can do better on both sides of the equation. Figuring out who's going to get the tox is another angle which people are looking at, which is potentially exciting too. All of that work needs to be encouraged, I think.
Yeah, I guess it's great to see that we have all the tools now that we can treat our patients, but what we are lacking behind now is having the biomarker to guide us to select the right treatment for the right patient. So I think I'm glad to see there's some data to be presented here at this meeting. I think we are one step ahead, but we are still far away from utilizing this personalized medicine for our patients, which is much needed to avoid over-treating our patients and avoid the toxicity associated with it.
Yeah, I too am really looking forward to that sort of series of biomarker talks that's coming up soon. In particular, the one about the KIM protein and using proteomics to help guide patient selection, because that David expresses really very much the concern I've had for a long time about adjuvant treatment. If you look at the absolute improvement in overall survival, it mirrors very nicely the absolute improvement of life-altering harm that these treatments can do. And so it makes for a very difficult discussion, when you're talking to a patient that's worried about their kidney cancer coming back.
Yeah, so it sounds like a lot of excitement around biomarker, which I also have a passion for, and I know Pavlos also shares a scientific love for understanding how to predict and treat patients. And I think, I agree, it's like we're one step forward, but I struggle, and some here are more experienced than I am, but it does feel like, I commend for these trials finally publishing, 5 years, the correlatives, which is wonderful and allows us to learn and continue making the next step forward. But I do think it's a kind of a Herculean effort for us and to push drug development to say we really need to make this either into a prospective design or, really continue working along that path so that we understand who's not responding, who can we de-risk, these things. And would love to see that happen in the adjuvant setting, obviously, where our goal is to cure patients, but to decrease the risk of that.
For me, looking at the abstracts that have been presented at this meeting and will be presented, the other sort of important, exciting sort of topic that it brings to my mind is just success, right? The incredible success that we've had, right? So when I was first starting my experience as a provider, as a pharmacist a number of years ago, as an oncology pharmacist, the median survival was about 9 months back in the days of just high-dose IL-2 and interferon. And now, because we have so much better tools, you're starting to see a lot of this research about what interesting novel combinations can we put together, looking at biomarkers to predict, the biology, what's the better biology, and can that help us with finding the right combination for that specific patient? So because our tools are so much better now, we are able to start asking these very important questions about how do I select patients, or how do I do treatment selection for this patient based on the patient's individual biology. If you only have one tool in your toolkit, then it doesn't matter what the biomarker shows, that's what you're going to use for everybody, right? So seeing this tremendous explosion of options, and now with growing evidence about HIF-2 alpha being useful and how that's going to play into, creating new combinations that we use, it's a really exciting time.
Yeah. And I think to add on to that point, the idea that our technologies, along with our drug development, have really advanced, I think it's also allowed us to look at other subtypes of kidney cancer, and better understand, how our current frontline treatment options might be affecting others, but looking at in a more biologic way.